Hello, everyone. So now we're going to continue with medications to treat fungal infections. And here we go. So those medications are called antifungal drugs. And the fungal infections are called mycosis. That's the proper terminology, mycosis. And there's two types of mycosis. Here we're going to start with systemic. That means that the infection is inside the patient's body. So systemic mycosis, the fungal infection is inside the patient's body. And the other one, I'll put it right here. It will be superficial mycosis. And based on the name, it's on the surface. That means that there's skin infections. Skin infections more often than systemic mycosis. So regarding systemic mycosis, they're very difficult to treat. The treatment is takes a little bit to start working, and the problem is the medications that we use to treat this type of drugs are very toxic. So that means we need to do follow-ups regarding liver function test and kidney function test. Okay, so here we have it: systemic mycosis, superficial mycosis. So we talk about that. Now, regarding the systemic mycosis, there's two types of infections. The ones that we call opportunistic infections, where the immune system is very low. Maybe they already have a primary infection, and that infection lowered the immune system of the patient, and now this type of fungus is able to take the opportunity and also be part of the disease that is affecting the patient. The most common one is Candida, and the name of the infection will be Candidiasis. Other ones that you may hear are aspergillosis, cryptococcosis, and mucormycosis. And then we have the ones that we call non-opportunistic. That means that the patient has a very good immune system, and even though with that, they still get an infection. The infection that we have here is sporotrichosis, blastomycosis, histoplasmosis, and coccidiomycosis. Now, not because these are non-opportunistic and it can happen in anyone, opportunistic fungal infections are more severe than non-opportunistic fungal infections. So let's start with the first medication for systemic. This is for systemic fungal infections or systemic mycosis. The name is amphotericin B, and the first thing, highly toxic. Highly toxic. And it's funny because before amphotericin B, the other drugs that we have, well, they were usually fatal. That's funny. That's that medication that we have to do a very careful follow-up is safer than the ones that we used to have. Okay, so amphotericin B is only IV. There's no PO medications. This medication is only for hospital use. Patient has to be monitored very closely. How do they work? It says here, bind to ergosterol. Basically what happens here, they bind to the fungal cell membrane. So just like penicillins and cephalosporins, amphotericin B is able to attach itself to the cell membrane of the fungus and rip it apart. That's how they work. This type of lipid Ergosterol, we as humans, we don't have it. We have cholesterol. That's why amphotericin B doesn't go inside our bodies and start killing bacterial, our cells left and right. Because we don't have ergosterol, we have cholesterol in the cell membranes of our cells. So what happens by ripping apart the cell membrane? There's an increased permeability into the cell, and that makes the fungus die. Okay, so that's how it works. The adverse effects, it says infusion reaction, nephrotoxicity, hypokalemia, bone marrow suppression. But let's go more in details on that. So the patient may have infusion reactions. So patient's gonna say, I have fever, I have chills, I have rigors, nausea, headache, and all this is happening while the medication is being infused. There seems to be this because this medication is very aggressive and produce irritation. We are gonna release chemicals that promotes inflammation. And these chemicals that promote inflammation are the reasons the patient has all these symptoms during the infusion. Usually the symptoms last 1 to 3 hours. And how can we prevent this? We have a variation, a presentation regarding amphotericin B, where the less one that produce harm is a lipid-based amphotericin B. So nowadays, the most common presentation to prevent an infusion reaction, to prevent all this set of signs and symptoms on the patient, amphotericin B is lipid-based. Now, you have to be careful here. We can pre-treat patients. And the most common combination is diphenhydramine or Benadryl plus acetaminophen. So diphenhydramine is gonna block the histamine release, and we're gonna prevent the vasodilation, the redness of the area, the flushing, the edema, and so on. And acetaminophen is gonna block all those pro-inflammatory cytokines. So acetaminophen is gonna block all those proteins that promote inflammation. So by giving this, usually it's between an hour to 30 minutes before we infuse. If we provide this to the patient, then we can not prevent 100% of the infusion reaction that they have it, but it will be a mild reaction, something that the patient will be more able to tolerate. Aspirin, we don't use it a lot here in the States, but there's some countries where aspirin is replaced by acetaminophen. Same thing to block the inflammation proteins, but we have to be very careful with the kidneys. Aspirin is very aggressive with the kidneys, plus amphotericin B is not a good combination. So here in the States, it's very rare to have aspirin as part of the pre-treatment for amphotericin B. Now, IV, pyridine, or dantrolene, those are muscle relaxants. And this is going to happen only, or they're going to be given only if rigors occurs. Rigors, rigid muscles. So we'll provide meperidine or dantrolene to relax the muscles, to prevent that rigors. Some hospitals, they have hydrocortisone as part of the protocol. If the patient has an infusion reaction, and we mentioned hydrocortisone is amazing because it can stop inflammation faster and better than the NSAIDs. Now, I already mentioned amphotericin B is a very aggressive medication. It's gonna irritate the environment as it goes in, so we're gonna have a phlebitis, inflammation of the vein. So they always advise always use a central vein to give amphotericin. So that means regarding central veins, we're not gonna use the ones from wrist, the ones from the arm. We're gonna use we need to provide a central line by the neck going into the main veins, the big veins. That way we don't burst that vein with the medication. And we have to provide heparin. If not, if we don't do this, there's a chance of having thrombophlebitis, and now we have a blood clot in a big vein. And remember, veins they go to the heart, so this can kill a patient. So we have to make sure that we understand all the pre-treatment that we need to do before amphotericin B. So we already mentioned histamine, acetaminophen, to prevent, not prevent, to make mild a mild event if the patient has an infusion reaction, and heparin to prevent the formation of blood clots, those central veins. Amphotericin B is nephrotoxic, so that means that you need to be aware that the doctor will be prescribing kidney labs, kidney function labs, and we're gonna have kidney damage, especially if the amount of amphotericin B exceeds 4 grams in a 24-hour period. So if you see that the patient's getting more than 4 grams in a 24-hour period, then we'll have damage to the kidney. So how can we prevent this? We need to flush the medication out. So we're going to be infusing 1 liter of normal saline, 0.9%, every time this patient gets treated. We need to prevent that leftover of amphotericin B in the kidneys, or there will be kidney damage. Obviously, don't mix it with other medications that produce kidney damage. And we have mentioned aminoglycosides, gentamicin, on previous chapters. Avoid NSAIDs as part of a regular treatment. Because again, NSAIDs like ibuprofen, naproxen, they can accelerate the kidney damage. And as it says here, you need to do labs every 3 to 4 days. Now, what is going to happen with amphotericin B? We're going to have hypokalemia. So you need to remember your lab values for calcium for potassium. And if the patient is hypokalemic, remember the organ that you need to do follow-up is the heart. What's happened to the heart? It's gonna become less strong in the relaxation portion, so it's gonna be unable to contract properly. Regarding the blood or bone marrow, anemias. Amphotericin B is gonna damage the formation of red blood cells. So that means that we need to do CVCs also besides kidney function test. So we mentioned fructose B is an IV medication. Usually we provide a test dose to see how sensitive the patient will be regarding the medication. Always check for phlebitis. We need to use a central lens for this, and the doses have to be individualized. So it's not going to be the same dose for every patient. Okay, now let's jump to the acyl drugs, also broad spectrum antifungal drugs. If the patient has a severe reaction to amphotericin B, the acyls can be a good option. They're less toxic. They can be used PO, just in case the central line is damaged. The only problem is here, it says here, inhibits P450 drug metabolism enzymes. In other words, the acyls, they inhibit liver function. That's the problem with this group of drugs. So if the patient is taking other drugs, we're gonna see increased toxicity from the other drugs because the liver is unable to deactivate those drugs, biometabolism. So regarding the acyls, all the medications on this group, they end in acyl. So we have itraconazole. Same thing, just like amphotericin B. It's going to inhibit the synthesis of ergosterol. So it's going to weaken the cell wall of the fungal. But at the same time, while it inhibits cytochrome P450 and the enzyme for them not to make more ergosterol for the cell wall, it's going to affect also our liver. So this is the problem that we have. Very good against the fungus, but unfortunately, we have this enzyme, so it's going to affect us too. Excuse me, sorry. So side effects, usually itraconazole is tolerated very well. If something happens, okay, regarding a severe adverse effect, we have cardiosuppression. So that means that the ventricles, they're not going to be strong enough to push blood forward. We already mentioned liver damage. The problem with damaging the liver is because now it's going to be unable to deactivate the other drugs that the patient is taking. So those are going to increase. So depending on the drug the patient is taking, then we'll see the side effect specifics for the other drugs. Because this medication is by mouth, NVD, nausea, vomit, and diarrhea. Fluconazole, also from the acyl group. Very good medication in PO presentations. Regarding adverse effects, they're more mild than itraconazole. So we have MVD because the presentation is basically PO. Voriconazole, one of the newest acyls. This one is used in systemic infection. So we have candidemia. So this is candidiasis and the blood emia. So now we have here the fungus infection going to the blood. So that means we have a systemic infection. So the place, also same thing for esophageal candidiasis and invasive aspergillosis. Aspergillosis usually is a lung infection. So patient's gonna have a lot of shortness of breath and symptoms regarding the lungs. How do they work? Just like the other ones. The rest of the acyls, they're gonna inhibit the formation of ergosterol. So that's gonna weaken the cell wall of the fungus and break it down. Voriconazole, because this medication is better for systemic infections. Parotoxicity, liver damage. Patient may have hallucinations with this medication. If the patient is pregnant, teratogenicity, or we already mentioned those malformations regarding the fetus. They can have allergic reactions, rash, anaphylactic shock, headache, and other drug interactions, especially those that affect the liver. Ketoconazole, another of the acyls. Same thing, inhibits ergosterol. And this is an alternative if the patient has severe reactions to amphotericin B. So just like the other acyls, if amphotericin B is giving a lot of trouble to the patient cannot tolerate it, then we jump to one of the acyls. So ketoconazole, has slow effects. So because of this, it's preferred in suppressing chronic infections. Ketoconazole is not very good when we want to treat something acute or severe infections. So regarding adverse effects, MVD, when it's PO, we already mentioned this can be a medication that can be used long term. So it will be liver damage. Has a little bit of effects on the sex hormones. It says here inhibit steroid synthesis in humans. So that means it's going to inhibit the formation of testosterone. So here we're going to see more of gynecomastia. Man boobs. So that will be the most common adverse effects regarding this section right here. And then rash, if we're talking about allergic reactions. Regarding posaconazole, is one of the newest medications, so we don't have a lot of information still regarding the adverse effects. So just follow the same pattern as the other ones. Medications is by mouth or PO, so we're gonna say MVD, long-term use, liver damage. So don't mix it with medications that are known to produce liver damage. Next group of drugs, the echinocandins. And they put this little hint right here. Candins sounds like candida. So that's the main use, but we have seen that it also works for aspergillus. Fungin is the how you can identify this group of drugs. Caspofungin, micafungin, and anidulafungin. So all of them are the echinocandin group. Okay, the next group is pyrimide analogs. Basically, what they do, they inhibit DNA. That's what they do. So we have fluorocytosine as the main drug. And same thing. It's going to be used for systemic infections. And one of the most common ones is Candida. Candida followed by Cryptococcus neoformans. So this is the first time that we mentioned this one here. Usually it's Candida and aspergillosis. Candida and aspergillosis. Candida and aspergillosis. But in this one, we're adding Cryptococcus neoformans. And same thing, usually it's not that strong of a drug, is less aggressive. So if for some reason the infection by Candida or by Cryptococcus neoformans is an aggressive disease, it can be combined with amphotericin B. And because of this combination, well, we need to be careful with the kidneys. We didn't mention that amphotericin B is very nephrotoxic and suppresses the bone marrow. So we're talking about all the different types of anemias. And flucytosine by itself is also toxic to the bone marrow and inhibit the liver. So by inhibiting the liver, in this case, same thing as we mentioned before, the liver's gonna be unable to deactivate if there's other drugs involved in the treatment of the patient. So there'll be an increase of them, and we'll start seeing adverse effects from the other drugs because of this effect. Okay, so far this is regarding the treatment of systemic infections. Now let's jump to superficial mycosis. Medication for superficial mycosis. Regarding mycosis, again, Candida. Candida is very common. It's found in all of mucous membranes and moist skin. Other fungus in the body, dermatophytes, the dermatophytes. Regarding Candida, thrush on babies is common. Vulvovaginal candidiasis on females, especially if the patient is pregnant or has diabetes. Those are the conditions where you're gonna see it the most. And onychomycosis, infections in nails. Onycho means nail. Already mentioned Candida. And regarding dermatophytes, there's a few of them. I think they're over here, yeah. So regarding dermatophytes, this is the ringworm that we see on some patients, especially under stressful periods of time. The infections are called tinea pedis for feet, tinea corporis for the body, tinea curis for the groin, and tinea capitis if we're talking about the scalp. Regarding candidiasis, this will be the proper term for this mycosis, candidiasis. We use fluconazole. It's an azole, where we talk about it. The highlight of this medication is it's a single dose. So this is very comfortable for the patient, one dose. If we use other antifungals, then the treatment can be 1 to 3 days, and it's topical. So I mean, we're talking about ovules. Regarding oral candidiasis, the most common one is going to be always statin oral solution. And then the other ones, clotrimazole, miconazole, only the patient is allergic to the statin. And amphotericin B, this is only used when the infection by Candida becomes systemic. Regarding the statin, we need to make sure that the patient is able to swish the medication in their mouth. If we're talking about thrush in babies, and the mom has to apply the medication inside the baby's mouth, since they cannot swish. Regarding fungal infections, we can use oral therapy like Lamisil and itraconazole, the down part of it. It can cause liver damage. Medication is PO, so we fight liver damage. The other adverse effects, MVD. If we go topical, then cycloporox will be your medication. Regarding cycloporox as a topical therapy, we don't see severe adverse effects. Patient may have irritation of the skin around the nail if they have a reaction to it. Okay, so here we go again. This is again a review of the azoles now for topical mycosis. So already mentioned clotrimazole, ketoconazole, iconazole. And the azoles are used usually for those dermatophyte infections, skin infections. Nystatin still one of the preferred ones for candidiasis. Itraconazole can be used for also for onychomycosis. Fluconazole, we mentioned, if the patient has a reaction to nystatin, or if for some reason nystatin, the patient becomes allergic to nystatin, or there's a resistance to nystatin, then it can be used for all the different presentations of candida in the body. Ketoconazole, this medication is advised for ringworm infections. And oxyconazole, sulcoconazole, just like the other azoles, can be used for all 4 types of tinea infections. Griseofulvin, this medication is very good for superficial mycosis. How it works, inhibits the mitosis of the fungal infection. So it doesn't kill the fungus, but inhibits growth. Regarding griseofulvin, it's a PO medication, so nausea, vomit, and diarrhea. And it's not mentioned here, but also liver damage. Griseofulvin is not advised on patients with liver damage. Nystatin, main use for nystatin is candidiasis and all different types of infections. So it can be intestinal candidiasis, esophageal candidiasis, thrush, vulvovaginal candidiasis. Usually nystatin, it will be the first drug of choice to treat superficial candida. Well, superficial and intestinal or GI candida. Medication is PO, so that means that regarding adverse effects, nausea, vomit, diarrhea. Topically, we're talking about creams, then we can talk about irritation of the skin. Okay, so thank you very much for your attention regarding this chapter, and I'll be seeing you pretty soon on the next one. Thank you very much for your attention.